Welcome to the 60 Plus podcast.
I'm Janet.
And I'm Joe. How are you, Janet?
I'm very well, thank you.
Oh, it only took 68 episodes to get you to say I'm well.
I
feel very
promised myself I
accomplished.
wouldn't do it, but today is an extra special occasion.
I feel very, very accomplished today.
Good.
Nothing can go wrong after that. What do we talk?
Well, I was going to say, I think you're going to even feel more accomplished
I think so.
after you announce our guest speaker today.
Yes. So it's that time of year.
Yes.
It's
That
Medicare open
Medicare
enrollment.
time of year, our favorite time.
Yeah, and we're very fortunate to have Kathy Grant from the Executive Office of Elder Affairs. She is the SHINE Program Assistant Director. Welcome, Kathy.
Hi there, guys. Great to
Hi.
be here.
Oh, thanks for coming in.
Yeah, thank you.
Tell us what SHINE is.
SHINE is an acronym that stands for Serving the Health Insurance Needs of Everyone, specifically everyone that is on Medicare. And we are part of a larger network of what are called SHIPs across the country, state health insurance programs, which are offered in all 54 states and territories.
And that's great because it's complicated stuff.
Indeed it is.
Yeah, we were talking before we started recording, and my head is swimming with,
I know I'm probably not going to say much this time.
you know,
I may just, be very quiet and try to absorb everything.
you say that, Janet, and then you.
Somehow I managed
Yeah,
to
you
say
do.
something.
All right, so why don't we start kind of at a high level, Kathy,
Sure.
and talk about what Medicare is, what's Part A, B, C, D, Medigap, Medicare Advantage. Just briefly, what all that is.
Sure. Okay. And this is where we usually start when we're working with consumers to give them a basic education, what we call a Medicare 101. So with Medicare, you have Part A, which is essentially your insurance, your hospital insurance. It covers you when you are an inpatient in the hospital. It typically covers about 80% of the total costs that you'll incur as an inpatient. And it also covers a lot of the services that you receive as an inpatient. So room and board, tests, the medications you receive, and so forth. Notably, the one thing it does not cover is doctor's services when you're in the hospital, because that is in fact covered by Medicare Part B.
So just don't see any doctors while you're in the hospital.
Yeah.
You're all set.
Yeah,
You don't
that
need
would
to do
that
that.
might help. But no, you do get charged, but it's a different part of Medicare that covers those doctor's services that you receive. So Part B again is medical coverage, and that would be seeing doctors, whether it's in the hospital or as an outpatient, as well as all the other types of things that you do on an outpatient basis, going for doctor's appointments, X-rays, tests, labs, things of that nature. Then we have Medicare Part C, which is actually combining A and B into an HMO or PPO-like structure. It is
Kind of like an employer's health insurance plan.
Exactly. It works very similar. These are also called Medicare Advantage plans. And then finally, one of the later entries into the Medicare alphabet, it really didn't occur until 2006, is Medicare Part D. And Part D is for not related. It happens to be for your drug coverage, but it's not D for drug coverage, although some people think of it that way.
It's just the next letter in the alphabet.
Another way to remember it.
Exactly. And that is to cover all of the outpatient medications that you take. So essentially, you're using your Part D coverage when you go to the pharmacy to pick up your medications. There are some medications that are delivered in a doctor's office setting, and they're typically covered by Part B. But anything that you're taking yourself at home, whether it's taking it via orally or an injection and so forth, if you're picking up it at the pharmacy, then it's a Part D covered medication. And the other thing that's important to mention with Medicare Advantage plans, I mentioned that they combine Parts A and B, but most Medicare Advantage plans are going to wrap that Part D coverage into their plan. So we have a lot of folks say, do I need all four letters of the alphabet when I'm choosing Medicare? And the answer is no. You're either going to be taking A and B as original Medicare with a Part D plan, or you're going to decide to go the path of Medicare Advantage, which bundles A, B, and D all together for you.
And then there's Medigap.
Right, exactly. So with original Medicare, which is again A and B, I mentioned the 80% coverage for A, and that actually applies for B as well. You, the consumer, are still left with that 20% that you're responsible for.
Which could be significant in
It
some.
absolutely can be. And it is certainly an option for consumers to take on that financial responsibility if they can. And if they choose to, especially if they aren't seeing doctors a lot and they don't anticipate they're going to have a lot of medical bills. But for anyone that wants to have complete umbrella coverage and have 100% of those Medicare approved costs covered, there are what are known as Medigap plans or supplement plans. They're known by both names across the country. And what those supplements do is for an additional monthly premium that you as a consumer pay, depending on the level or type of supplement that you choose, it will either pay everything for you, which means any deductibles that you have for your A and B and any copays, or it will only pay your copays and you as the consumer would still be required to cover the Part A and the Part B deductible. Now, the Part B deductible is relatively modest. It's $240 this year. We don't have the numbers yet for 2025.
240 is for what?
This is your Part B deductible. Think of it as like any deductible for any insurance. It's the amount that you owe out of pocket before your insurance is going to start kicking in their portion. Okay.
Basically one visit.
Exactly. If you're even lucky to get by with a $240 visit.
Partial hour.
Right, exactly. With Part A, though, the hospital deductible, it's quite a larger chunk of money. For every time that you're in the hospital, the first $1,632 is for 2024 is going to come out of your pocket. And then after that, Medicare will start to pay the 80%. And then again, if you have a Medigap, they will cover the remaining 20%.
Okay.
So unlike most deductibles, that's per hospital visit.
And that's a great point to bring up. The Part B deductible that I just mentioned, the $240, that's once per year. That's annual, and then you're done.
$240 per year.
With the hospital visits, and we see this a lot, if you go into the hospital in January, you're going to owe that $1,600. If you get out and you go back in, you are going to owe another $1,632.
So
it's what's called benefit periods. Yeah.
So if you go back into the hospital, does it have to be for the same condition?
As long as you're in the same benefit period, you're fine.
Okay.
But it's when you've been out for that period of time and you go back in again.
Okay.
Yeah.
That's A and B, and you pay premiums for parts A and B, correct?
You pay a premium for Part B. This year, it's $174.70 for the majority of individuals. There are folks that are in a higher income bracket who are subject to something called the Income Related Monthly Adjustment Amount, or IRMA. And that can range for most folks that are in income brackets. I think this year for a single filer, a tax filer, I think they can earn up to $103,000, and for couples, it's double that amount. Anything above that, they're going to start paying a premium on top of the $174.70 premium. So,
and that's income from salary and wages.
Well, it's essentially the income that you're claiming on your tax return every year. It's your adjusted gross income on your tax return. But the important thing to know about that as well, though, especially for people that are new to retirement and their income is really fluctuating a bit right around the time that you retire versus the first couple of years of retirement, is that if you are hit with the IRMA surcharge and your current year's income really doesn't look like what it was a couple of years ago, is essentially with IRMA, the feds always look at 2 years prior. They look at your tax return 2 years prior, and they base whether or not they're going to charge you that IRMA premium on that 2 years prior. Well, if you were working 2 years ago or there was some significant event 2 years ago that caused your income to bump up, you do have the option of appealing through the Social Security office to have them reduce that premium amount for you based on the fact that you're no longer earning that income that you were earning 2 years ago.
Right. Okay. All right. Yeah. And that's for Part B coverage?
That is for not just Part B, but believe it or not, when you pick up a Part D plan, which is yet another separate premium, when you are subject to IRMA, you will have a premium placed on both your Part B premium as well as a surcharge, I should say, placed on both your Part B premium as well as whatever premium you're paying for Part D. So, and the same rules apply in terms of getting that adjustment for your Part D IRMA if your current income isn't reflective of what your income is going to be going
So
forward.
basically, you should retire at 63, so you have those 2 years to make no money.
Well, if you can.
Yeah.
If you can. I'm glad this is also simple.
I wish.
And we're just talking about the basics right now.
Right. So you're the assistant program director for Shine, but we said every state and territory has their own assistance program to guide people through this.
Absolutely. They all have different names. I know in Florida, they're also called Shine, but you see a lot of different acronyms. But at the end of the day, they're all part of the SHIP network, the State Health Assistance Program network. And for anyone that wants to find out who the best person is to go to in their state, the Medicare.gov website actually has a search function that will allow you to select your state from a drop down and will bring you right to the phone number and website of the SHIP program in your state or territory. And then from there, if you contact them, they're usually able to find a local counselor that can meet with you.
The way we got on the subject, and then we're going to talk about the changes coming up this year, was a listener sent me an article from the Wall Street Journal. And in that article, there was a link, and it's shiphelp.org. And that lists all the states.
Yes. That's another place that you, So SHIP Help is actually a website that a lot of SHIP counselors use as well, or a lot of the Shine counselors use. The tremendous amount of training on there that supplements the training that we do for our counselors. But yes, there's also a public-facing version of SHIP Help, and that's another place for people to go and get some of their questions answered, especially if they aren't able to connect with a SHIP counselor in their area.
All right. So let's get to why you're really here to talk about the changes that in the past people would frequently just roll over whatever plan they had last year into the next year. Probably not a thing you should be doing automatically this year, correct?
It's really not a good idea any year.
Okay.
Because even prior to a lot of the changes that we're going to talk about, the thing with plans is that they have the ability, and we've certainly see them do this from year to year, to make a lot of changes to the plans that people are in. So there's changes, most importantly, to their formulary. So you could be in a plan, be happily going along, getting everything covered, not make any changes during open enrollment, and then go into the pharmacy in January and find that your plan that you've kept is no longer covering a medication that you need.
Wow.
In addition, the premiums can swing widely from year to year. There are some years when plans will start with especially newer plans to a market that will start with a very competitive monthly premium, sort of to gather, consumers. And then consumers don't realize that the following year, through just market conditions or whatever, the plans have the right to raise that premium certainly as much as they want to, and they do. And then also plans, even if they keep drugs on their formulary, there are a lot of instances in which they add restrictions, quantity limits, prior authorizations that might not have been there before. So it's always prudent to check your plan, even if it turns out that the plan you're in is still the best one for you next year, and we've seen that. But things may change in terms of your doctor now being required to put you through step therapy or things like that.
Okay.
So that's why setting it and forgetting it has never been a good idea.
So, and they're not obligated to notify you of these changes?
They actually do send out what are called annual notices of change. So they will certainly let you know of significant changes to their formulary, changes to the premium that they're going to be charging. But the reality is that for a lot of the folks that we work with, consumers we work with, they get a lot of mail during this time of year, and they might not necessarily open up that letter and read it and really understand what it means in terms of their coverage choices and decisions they might need to make.
Okay.
I'm not even eligible to sign up for Medicare yet. I will be soon, but the amount of mail I'm getting already is crazy.
Oh, it starts usually from the age of 63 on. I think they have access to mailing lists and voter registration rules. They know how old we are.
It's not a secret.
Yeah.
Darn, I've been trying to hide it.
I think you gave that up when you started hosting the 60 Plus podcast.
I know.
Yeah.
I know. When people ask me, you have a podcast? What's it called? I'm like, 60 Plus.
All right. So this year there are big changes. More so than usual. Oh,
Absolutely.
Before we get to that, I did have a question. Say you're very diligent about picking your Part D plan, for instance, and then partway through the year, doctor says, "Oh, new prescription," and it's not covered. What happens? You're responsible for that?
We do see that happen. There are some options. Just being prescribed a new medication that isn't on the formulary isn't an automatic get out of jail card where you then can just say, I'm just going to change and find a plan that does cover it. Unfortunately, that would be the ideal situation. But there is always first of all, all of the plans are required to have a certain number of drugs in all categories within their formulary. So the first course of action would typically be ask your doctor or see if your doctor can work and choose an alternative medication that might do the same thing for you that the one that he or she has prescribed. If that isn't an option, or if you've tried that before, if your doctor feels strongly about it, the doctor can always submit a formulary exception request. There's no guarantee that that is going to be approved, but it's always an option that folks can follow. And then worst comes to worst, there are what are called special enrollment periods throughout the year that individuals may qualify for. It's circumstances if they've moved to a different location and, they need to change drug plans because their plan is no longer offered in their new location. They may be receiving some type of prescription assistance through either a federal or a state cost assistance program. And some of those programs do give individuals periodic ability to switch their plan mid-year outside of one of the regular enrollment periods. So when we run across that situation, we try to pursue all those avenues to see what the easiest one is to get to maybe get that person the coverage they need.
So I know I've been teasing the talk about all the changes. Let's get to it.
Okay.
What are some of the big changes that are happening this year?
I haven't seen as much publicity about this as I wish there was, but some of this has been okay, wonderful. But this has been a while in the making, and these are outcomes of legislation that was passed a couple of years ago, the Inflation Reduction Act, which was passed in 2022. And there's a long list of sort of drawn out repercussions, positive repercussions that are coming from that. The one that is happening this year that is, so last year, as an example, one of the early things was the cap of $35 for
insulin.
The insulin. Exactly.
I did see a lot about that.
Right, exactly. Yeah, that was very well publicized. So last year, this time, we were looking at for anyone who was in a Part D plan and particularly who had very expensive medications, they would really not get any relief or be moved down to a point in the year where they would not have to pay anything, any copays. They would have to put out of pocket over $8,000, which is a lot of money. Thankfully there was a cap in total.
Just on prescriptions.
Just on prescriptions, exactly. Not including their premiums either. This was just their out-of-pocket expense. But with and a big round of applause for this, with the elimination of the donut hole or coverage gap, we're now down to what essentially are 3 phases of drug coverage. Drug plans, not all of them have a deductible, but many of them do. The majority of them out there do. And this year, Medicare has allowed drug plans to have a maximum deductible of $590 or $595. I don't quote me on that.
Somewhere under $600.
Up from $545 in 2024. Some plans have a zero deductible, okay? And that's fine. That means what it indicates, which is that you're going to go right into paying initial phase copays right from the first visit to the pharmacy. But like every deductible, for anybody that is in one of these plans with a $590 deductible, they are going to have, that money's going to have to come out of their pocket before they start getting the benefit of the drug plan, throwing in their share and giving them lower copays. So deductible phase, the next phase is called the initial coverage phase. And that is where you're going to be settling into a more regular copay amount. Depends on the tier of the drug that you're selecting. Many of the plans for tier 1 and tier 2 drugs, even if there is a deductible on the plan, they don't even apply those drugs towards the deductible. So you get the benefit of low copays right away on some of the more routine drugs that have been in the market for a long time.
Like statins or something.
Exactly. And some of the blood pressure medications and things like that. With the elimination of the coverage gap, one goes from initial coverage phase right into catastrophic. And the big news that Joe has been waiting for me to say is that whereas last year that catastrophic level was $8,000 before you'd get the benefit of going into catastrophic and getting to a zero copay, that has now been moved to the level of $2,000 of total out-of-pocket costs.
significant difference.
So when we're talking about folks that have very expensive medications that, right up front, they would have a lot of copay to put on the counter, right from day one. Some of these folks are going to be hitting that $2,000 cap very quickly at the beginning of the year. And they may be looking at having zero copays as they go through the last 3 quarters of the year, let's say.
And without getting into specifics, because we talked about this before recording, it gets confusing. There are even situations where you don't get to $2,000 out of your pocket before you get to zero.
With the when the coverage gap was in place, there were, and there still are, what are called enhanced alternative drug coverage plans. And these can be not just Part D plans, but also Medicare Advantage plans have enhanced alternative coverage as well. And in the days of the coverage gap, those plans would contribute more towards the cost of these medications in that coverage gap to sort of mitigate some of those copay increases in the coverage gap. With the elimination of that coverage gap, those plans, those enhanced plans, are now actually contributing towards what is called true out-of-pocket costs. I'll give you an example. If you go into a pharmacy and you have a medication that has a retail cost of $300, let's say, and your copay for that is $50 for that medication, not only will your $50 start counting towards the $2,000 cap that we're all working towards, but the plan that you're in, if it's an enhanced plan, they are going to look at that total retail cost and they are going to contribute a percentage of that total retail cost to the true out-of-pocket cost as well. So let's say it's a $300 medication, you've paid $50. Let's say that plan as well is going to contribute $50. You're actually $100 closer to the $2,000 instead of just your $50. And that's a very simple mathematical. I'm not saying it's always that simple, but that just goes to illustrate that it's more than just what you, Joe, are putting out of your pocket. It is what you and the plan are putting as well. And there are some other very complicated nuances depending on plans that there may be other contributors to that true out of pocket. But I think what it's important for folks to know is that you may, when you're looking at plans and you're projecting what your cost is going to be, you may actually see yourself projected to be in that catastrophic zero copay phase sooner than when you yourself have put $2,000 on the table.
Not confusing at all.
No, that's good. That's good.
It is good. Yeah. What are some of the pitfalls that people can fall into? I did read an article and talked about how in some Medicare Advantage plans, there's a limited list of doctors or hospitals even that you can go to.
Yes, Medicare Advantage plans have a lot of positives around them, and as you can see, they do a lot of advertising. You really don't see Part D plans or even Medicare itself doing a lot of advertising. Right, exactly. But not to short sell the Medicare Advantage folks, because they cover everything. They're required to cover everything that Medicare covers, and they do offer a lot of additional benefits to seniors that are very important to seniors, things that Medicare does not cover.
Dental and vision.
Dental, hearing, vision, gym memberships. And one of the more popular items that's come about in the last couple of years, they've really been allowed to expand their menu of additional options, are over-the-counter spending cards that can be used at grocery stores or at pharmacies and things like that.
Okay.
These are real draws for the population that they're targeting, but the problem is that folks can sometimes get blinded by those additional benefits. And what we always tell folks to use as their guide is, if you are interested in pursuing the Medicare Advantage path, the very first thing that you need to do, two things. You need to check with all of your providers and find out what Medicare Advantage plans in your area they are taking, because that's paramount. Okay.
And they vary from state to state.
Absolutely vary from state to state. We talked before about what Medicare Advantage is, working like an HMO, PPO. They are very strict in terms of you really can only use them, within a network in a certain area. And that applies no matter what state we're talking about. So if we're talking to somebody in Massachusetts, their HMO is only going to work in a certain area in Massachusetts. If we're talking to somebody in Florida, the same thing applies there. If they're looking at a Medicare Advantage plan, it's really only going to take care of them within the network that is set by that HMO.
So you really have to look at it by provider. provider then too.
Yeah, well, absolutely. So we strongly recommend that they look at it by provider. In fairness, there are a couple of Medicare Advantage plans that have a more national
I was
network.
just going to say, if you
Yeah.
travel,
Well,
even domestically,
right,
it can be a
right,
challenge.
right. It absolutely for the majority of the Medicare Advantage plans it is. But as I said, there are a couple of vendor names that are popular and familiar, and you see them offered throughout the country. And so there is some flexibility there in getting coverage if you're not in your home state. But the other thing that we tell them to be very mindful of is to also check the formulary of those plans. Because remember, with Medicare Advantage, you have to take the prescription drug coverage that comes with that plan. You can't go out and find a separate Part D plan that has everything that you want on the formulary. And if you did that, you'd actually be kicking yourself off of the Medicare Advantage plan. So those are the two key things we say. Make sure your doctors, before you even venture into deciding on a plan, find out which plans your providers take, not just your primary one, but anybody that they would refer you to, and then take a look online. All these plans have very, very active, very filled websites that will give you all the information you need. Make sure that all of the drugs that your doctor has prescribed for you currently are on that. Once you find that out, then you can start shopping amongst those Medicare Advantage plans. I always say, look at all the other things they provide as a bonus to you. You know, it's great if you can make sure your medical and your drug coverage are in place. Then it's wonderful that you can take advantage of a flex card that gives you $150 a quarter or whatever it might be. That's a bonus, but it should never be what drives you to a Medicare Advantage plan.
Fair enough.
All right. We're running out of time, and I'm sure there's a lot more we can cover. But what I'm hearing is for people that are currently enrolled in Medicare, you got to review your plan and your coverage and the drugs that you're taking and your providers more so this year than ever before, even though it's always been advised.
Absolutely. Because the other thing I'll mention that's important is there has been a lot of, with the advent of these changes like the $2,000 cap and other things that are coming down the pike, which are negotiations on some of them very, very expensive drugs that are out there, which people will start to see the benefit of that next plan year for 2026. There are a lot of plans that have actively exited some markets across the country. So not just in our state, but across the country. And so all the more reason to make sure that you're not left flat-footed when January comes and you haven't had a chance to make some decisions for the best for next year.
I think I'm finally convinced that it's really advantageous to take advantage of a program like Shine, or in other states it's called SHIP, because it's complicated. It's just I wish it weren't. But you talk about the websites that these health insurers have, and I've been looking. I'm confused. I mean, it's a lot of information, and being able to kind of make an informed decision about it is.
We try to break it down into digestible bites. I mean, I would say a typical appointment with us is an hour, but that doesn't mean that's the only time you can come and see us. And we have a lot of folks that then the earlier in your Medicare journey you come and see us, the better, because we can do it as a series of meetings until you feel like you're confident enough to make these decisions going forward on your own.
Just to confirm, I do want to mention the timing on this again. If you're enrolling in Medicare for the first time, about when is the ideal time?
So your initial enrollment period for folks that are turning 65 starts 3 months before your birthday month. It includes your birthday month and then runs all the way till 3 months after your birthday month. But we always stress the earlier the better. If you wait until your birthday month, you're already delaying the effective date, and it'll always be delayed by 1 month. But if you get in there one of the 3 months before your birthday month, then you will be able to have it locked and loaded and ready to start on the first of your birthday month.
Okay, great.
When you apply, do you go to ssa.gov?
You can go to ssa.gov. You can you can set up what's called a socialsecurity.gov account, or I think they may be even trying to unify all .gov accounts now, but you can certainly set up a personalized account with them and do all that right online. But they also take appointments, and they have a directory on their website that will tell you where your local office is. Some people prefer to go in and kind of, do everything in person and feel like they've got everything buttoned up correctly. So.
And I think it's really important that people get unbiased advice.
That's
They're
that is what we are all about. And again, no ship counselor should be saying this is the best or this isn't good. We just try to give you all the information that's out there and all the tools, but we really do leave the decisions ultimately up to the individual, because there's nothing more individualized than Medicare coverage.
okay.
Great.
Anything, Janet, before we wrap up?
No, I think that's
You were,
good.
you were right. You didn't really say very much.
My head hurts.
I'm sorry, Janet.
It's not your fault, Kathy. Thank you for coming in and explaining all of this. In some respects, I'm more confused and less confused than I was before. No. It just means that you've done your job in explaining some of the intricacies that I just have to digest.
Right. And the important changes coming in 2025. And, again, really focusing in on checking out your plans, right? And making sure you're in the right place.
True.
All right. There'll be some show notes with links to great resources. So on the Spotify playlist.
Mm-hmm.
And Kathy, thank you so much for coming in from Shine at the Massachusetts Executive Office of Elder Affairs.
Thank you for having me.
You're more than welcome. This has been great.
Yes. Thanks so much.
And that's it.
I'm Janet.
I'm Joe.
Bye.